So only one thing what I found missing in your presentation is, because you defined recovery from anesthesia may be defined as a state of consciousness of an individual and he is awake or easily arousable and aware of his surroundings and identity. That's why we at the end of anesthesia, especially GA, we always say, open your eyes, tell me your name, what is your name, all that the questions we ask, because patients should be able to remember all that and communicate to you. So the phases of recovery from anesthesia, they is divided into early recovery phase, breaking with a recovery of vital reflexes, recovery phase, which is called clinical recovery and home readiness, and late recovery phase, which is full recovery and psychological recovery. So in the early recovery, once you discontinue the anesthetic agent, it makes the patient wake up, recover mainly the protective reflexes, preventing aspiration and having a normal breathing with a good motor power. And they traditionally continue to stay in the PACU for some time before you shift them to the ward or the room. And they are able to respond because they go to the stage of what is called MAC awake, minimum alveolar concentration, at which they are able to be awake at this. And the increased ventilator results more rapid decline in alveolar anesthetic concentration, which hastens recovery. Then in the intermediate recovery phase, the patient regains more power, coordination, the dizzy feeling stage usually lasts for 1 hour after short anesthetic. Outpatient may be considered fit for discharge with responsible escort. Then long-term recovery, the patient is fully coordinated and highly intellectual function. These are back to this original pre-surgical level. Now, how to assess the recovery from anesthesia? We use these two scales, what is called the Glasgow Coma scale and the Aldrich scale, with which we decide with the various levels of recovery. Glasgow mainly for CNS recovery using the best possible verbal and this thing. If the patient is intubated, you have to add the letter T for that. Then you get only a total of 10 points. And what this do? And whereas in an unintubated patient, it is maximum score of 15 with a lower score 3. And for discharge from normal ward, you have these 5 parameters: activity levels, respiration, circulation, consciousness, and O2 saturation. Based on that, you can decide whether the patient is fit for that. Now, after assessing the recovery, now we say which patient is having a delayed awakening or emergence from general anesthesia. So it is defined as a state of responsiveness where he cannot be aroused, and it relates to something underlying undiagnosed condition or a medical error. So the risk factors can be classified as patient factors, drug factors, surgical anesthetic factors, and metabolic factors. So if you put a chart like this, you can easily classify all the things that we have been telling into one simple thing. So you can see extremes of age, gender, genetic variation, comorbidities, body habitus. So that is obese people sometimes, because if you use a volatile for a long time, they may take a longer stroke and all those things. And drug factors like dosage, time of administration, blood gas solubility, excretion, etc. Surgical factors and metabolic factors. All these things like hypernatremia, glycemia, hypothermia, hypothyroidism, everything comes into this particular chart. So you can do that. Apart from that, rare cases of central anticholinergic syndrome by usage of scopolamine and hyoscine or after benzodiazepines or IV volatile agent, which also can manifest as delayed awakening. And dissociative coma, myxedema coma, thyroid failure, Hunter syndrome, valproate toxicity, drug abuse, lidocaine infusion, all these things also sometimes can be a cause of delayed recovery. And apart from general anesthesia, sometimes delayed recovery anesthesia if there is a spinal or epidural hematoma, which can be happening because of vascular malformations or anticoagulant therapy, which indirectly causes an increase in the venous pressure. And that is diagnosed only by an MRI and that to be treated by surgical decompression. And the epidural catheter, intratracheal migration, and faulty infusion pumps, potentiation by fentanyl, clonidine, which are all added as additives to the local anesthetic. All these things can also be the cause for delayed recovery. Now, once this is the flow chart for assessing the cause of delayed recovery. First, up to 30 minutes. That is why that early classification of immediate recovery, intermediate recovery, and late recovery will be useful here. Up to 30 minutes, you can use non-invasive blood pressure, ECG, oxygen saturation causes. Then up to 2 hours, can have additional monitoring. If the patient does not recover even after 30 minutes, then up to 2 hours, you go for further investigations and monitoring, and then try to think of all these possible causes. If it takes more than 2 hours, then you have to go for much more serious investigations like MRI, CT scan to rule out neurological problems, and go for other specialist consultations like neurological consultations, and rule out any cerebral embolism, undiagnosed meningioma, cerebral aneurysm, hypoxic episode. All these things have to be ruled out. Now, the management also, you have a flow chart where unresponsive patient, stop all the anesthetic agents, switch off the change the breathing circuit, change the machine and gas, everything. Then start assessing the patient's airway breathing circulation. Then look for the possible causes. And then elimination of remainder of anesthetic by 100% oxygen, hyperventilation, and forced diuresis. Then warming the patient, thinking of hypothermia if the temperature is less than 35. Then consideration of metabolic abnormalities like hypoglycemia or hyperglycemia, hyponatremia. Reversal of your neuromuscular blockage. If it is insufficient, then giving another dose. Then substitution therapy like steroids, thyroxine. So patients who have been regularly taking steroids, they have not been given the initial substitution dose, they can go in for delayed recovery. So all these points you have to take into consideration, and then get a neurosurgical opinion for them, and monitor the patient in the intensive care unit till they completely recover. Okay. And practical steps in the management of the recovery is first rapid ABC, 100% oxygen, then assess GCS, review the anesthetic chart, what are the drugs timings, consider naloxone, flumazenil, neostigmine, and doxapram, then do capillary blood glucose, correct high or low, measure temperature, take the warming step, arterial blood gas, correct hypoxemia, hypercarbia, acidosis, full clinical examination, consider further investigation, blood test, and other things. If patient remain unconscious, decide whether the patient should be managed for further course of action, and consider dissociation test where there can be diagnosed or absent. So these are all the points that you have to take, and this is a very useful practical point of view and as well as from the examination point of view. Okay, so that is what I thought we do.